Good. So case number 5, if you can see the presentation slide, is a 79-year-old male who had initially presented with the classical angina symptoms with risk factor of hypertension, hyperlipidemia, had a positive stress test, MPI, with multivessel ischemia. And cath post showed a 3-vessel disease with the circumflex LPL, and there was a RCA disease. Since the syntax score, though it was 3-vessel disease, and if you see that patient had a 3-vessel disease, had a bypass cabbage referral. However, he refused. Then he came here and we did the PCI of the right coronary artery as well as circumflex. Today, he's here for the PCI of totally occluded LAD. If we can start showing the angiogram. So medication-wise, he's on aspirin, clopidogrel, Lipitor, lisinopril, metoprolol. They have checked the PRU, and PRU is 192. So if you can see the angiogram, this is a dual injection. RCA stents are patent. Go minus. Yeah. You see the feeding vessel, the LAD, good distal target. And going to the CTO score calculation wise, only thing you would say is you can see the cap, that is tubular or not a brand. And then long segment, no calcium. We are not sure no true side branch at that area. So this is where we are with the LAD CTO. I know you were having discussion about CTO who. Which patient should be getting revascularization?
Yeah, and looks like we said, maybe LAD, symptomatic patients with LAD would be definite. So comes out as a definite.
So this,
I don't see the proximal cap really. It's a very difficult to see. It's very much in proximally. There's a lot of branches overlap. It's going to be challenging to go to isolate it. But
let me just, no, not too much. I need to see. Ready?
Well, we see
here
something.
You don't see it well at all. You see the origin of the LAD, and then there's that large diagonal. Yeah.
Yeah. Yeah, I think it's challenging. There's this. What do you think about your approach given this challenge? No.
I am going to start antegrade itself. We have, Corsair, and I'll start with the fielder. That would be the first wire of choice. You always want to try polymer jacketed wire fielder, whether you want regular fielder, XT, any of that.
Yeah.
To see if there is, micro channels or something. So I'm going to start with the regular fielder, and then we start wire escalation as we keep going.
Well, I know some
Given heparin, and our ACT is about 290. Yeah.
I know some European operators are going to be very keen on starting retrograde here, and definitely some Japanese ones. So I don't know, Dr. Stone, what do you think the rationale is for that? Although, given the there's more and more calls to try antegrade all the time.
Well, first of all, I'd like to see it. It looks like on the AP cranio that there might be a cap. You didn't see it at all in that kind of shallow caudal, but I would wonder if in an LEO cranial or in an REO caudal we could see the cap. That'd be number one. Number two, you'd like to always try to go antegrade, but you need to see the cap for that. If I couldn't see the cap, then I would use ultrasound to try to identify the cap by ultrasound. But if there's absolutely no cap and you really can't see it, then I would have a low threshold to switch to retrograde.
So start on the grade by low threshold to switch. Dr. Barman, what do you think? Would you go retrograde?
I wouldn't. I think a broad point is obviously to do the things that you're good at. So if you're very facile with that strategy, it's not unreasonable for a case where the cap so clear. I would add that I think it's critically important, maybe for obvious reasons, to really, before we start engaging, take multiple views to really understand the anatomy. And I know that they've done that. I'd also, I think even before we get to the lab, and I'm sure the RCA didn't look overly complex, just I think another panelist had mentioned this in a previous session about maybe the order in which these interventions
You want to do
are done,
retrograde of the RCA so we
potentially
can see,
starting with
right?
the CTO first, so that you're not compromising a donor.
Antegrade also, okay?
Certainly if you fail and CTS is still on the table. And
Okay, go RCA.
lastly, someone may already
Go.
be committed to
Retrograde.
DAPT, having stents in the other vessels, so should there be a important bleeding complication, stopping DAPT can get complicated as well.
Dr. Huber, you seem to be agreeable, but I don't know to whom.
There's cranial picture is better. We'll go more RO, I think.
Well, I have a
That
very
time
similar
will be
opinion than Greg has. So it's fine to have a try here, but
Okay, some die.
from the first picture where we really haven't seen where to go antegrade, we would eventually have started retrograde here.
Just the glass piece.
Retrograde. Yeah, Dr. Kearney
That
and
is
now
the only
Dr.
one.
Waxman.
Yeah.
Any idea?
Other
Yeah,
thing is,
the
do
West
we
Coast.
go? Arya.
Yeah, I think these LCL LEDs are always challenging. I almost never use IVUS guidance here, but you could put a wire in the diag to try to see, because I think the guide is sort of favoring you away from the osteo LED potentially too. But this might be a case where you can actually see it. I don't use that technique
So
very
the
often.
question
I'm not
is,
very
do we
good at
go
it
with
as a
the
result,
FCL,
but,
right?
if there's
Yeah.
not a lot
Let's
of
see the
guidance,
picture,
you
yes.
might
Yeah,
get a
okay,
clue.
good.
But I think more than likely we're going to need retrograde to solve some of the problems, because especially the LED,
think
you have so
it's,
many branches
pointing
and other
towards
ways you
the
can get lost.
circle.
Now we're seeing a little bit of a
That's
beak
the
here
major
though.
challenge.
So it's
coming
Get
not
us a
uncommon that
FCL.
we need some retrograde to solve that, and the main issue is to trying to do reverse cart away from the left main, so we're sure we're okay there.
Well, that's the only view that I start seeing it now. Can you
6
freeze
times,
it?
right?
Can you freeze it, please, at the
6 is
spot that
also
we
fine.
can see?
Yeah.
And then you can try to aim there.
It's a short.
There you go.
So it's a short left main. You see that?
Yeah.
So I think
Finally,
guide
we
is
can see,
selectively
yeah.
into the
So is this is the view, or you just poked with the wire? Because
the
we
view.
didn't see it before.
that's the
This is
No,
the
no,
view,
no,
right?
No, this is the view.
This is the view.
We saw it actually in the first
It's the
picture.
holy grail.
It's the
Wait,
REO.
go on.
That's what I'm about to say,
Extreme
all about
REO
imaging.
cranium, which
Yeah.
always helps you in this
It's
area,
going
or the REO
Don't open the
caudal.
guide yet.
Yeah,
we are.
let's
Don't
see,
do
are
that.
we in that pouch? And if we're in that pouch, then you can
We are
put
in
the
the pouch.
microcatheter. But are we in the pouch?
Don't open yet.
But
We
you
are in
ha-
the pouch.
Are we in the pouch?
Yes.
But just go back to the entry. If you have doubt, this is a very large vessel. If you do IVUS backward on the adjacent vessel, like the diagonal, you will see where the entry is. I mean, it's not going to be big.
Okay, some die.
You'll be able to, and that will save you all the dye and all the other contrast. We just already spent
You're
like
in the
30
pouch, but
to see
the,
at
but
least
the
of one.
corsair goes in the diagonal. Yeah.
A lot of this is starting cleanly, so as you're lining up your wire, if you take some cines and just one or two views to really tell where you are. I mean, you can do it with IVUS, but you can really do it angiographically by doing some orthogonal views, and it would be an extreme areocranial like you got into here, an extreme areocaudal.
Yeah, no, finally we find this view. I think it's critical to understand how the differential origin of LED diagonal is. I think this view is great. The difficulty, you already saw it, the wire went there, but the support catheter was just too straight and too non-flexible, one can say, to approach there over the soft part of the wire. Very
I
tricky.
should have
So a
gone.
lot of
Very
times I won't use the catheter just
Field of
yet.
fine
Just
cross.
start with wiring first so that the wire is cleanly free and see how far you can get.
Yeah.
A lot of times this will just direct you the wrong way and then you can't track it in.
Yeah.
If the filter ready,
Get me the fine cross.
fine cross and filter, give both the.
Yeah, I was thinking
I have
to
Corsair. I'm going to change it. Yeah.
Yeah, we change the
This is
Corsair.
so
I think the Corsair is
yeah.
just too straight in the beginning. The other option might be you put a wire in the diagonal, just a BMW or whatever wire you like. So it always stabilizes your guide a little bit, and you can also see. So to avoid it, let's say. So this wire.
No, the one other thing is take a FCL guide that will be dedicated into the LED. Rather, the VL guide in the short left main is not a good
Yeah.
guide. Let's see. We'll try once more with this fine cross. Otherwise, we have to change the guide.
Yeah, but
You have FCL
yeah,
ready. Okay.
I'd say put the wire in the diagonal so you can see where it is.
Now we are back. We changed to fine cross and fielder again. And let's see if this will help us.
Fine cross is not steerable as the Corsair, but is not,
Yes.
doesn't have this bulky edge. So it may be able to make that curve a little bit towards the LAD. I guess not really.
Okay, now, right?
Or you may, yeah. Yeah, or you get a more dedicated
So now
stiffer
you see
wire.
that you need a stiffer wire here.
Yeah, go with a
You
stiffer
need
wire.
some
See if
stiffer
you-
wire to drill.
Yeah.
Or can you
So
put
with
I
a
think we
stiffer
changed
wire,
STL
and
guide. What do you
as
think?
Dr. Fox suggested, if you're able to advance a wire beyond the radio pack portion, and it's a little bit stiffer, maybe the catheter, hopefully the catheter
We'll
will,
change to Miracle here.
hopefully the
One
catheter
second,
will
okay.
follow.
or can you put a wire and a balloon into the diag?
Yeah, exactly. I think we need to advance a little bit the.
Yeah,
No, to occlude
somebody
the
said it.
diag.
I think it's a good idea to have a wire in the diagonal. Number one, there's a lesion in the diagonal and you want to protect it. But number two, it'll also help stabilize the guide. And then by withdrawing the guide a little bit, that will actually angle it towards the LAD.
Some die.
And you can even do a low pressure inflation in the diagonal, right?
Three.
I have.
Yeah, I wouldn't start doing
Am I
that.
there?
Yeah, we are there.
You got a long case.
I mean, technically, if you inflate it on the diagonal exactly at the bifurcation, the wire and the catheter will stop buckling into the diagonal.
Yep.
You can inflate it to a balloon the diagonal and just block it, so the wires don't go.
All excellent points, but I have
Meanwhile, you
this
made
just at the proximal cap.
yeah. And which wire are you using now? Gaia 3?
No, supposed to be Gaia 3, but since
Supposed to be Gaia 3 according to
I
the
had to
app.
make
You
a
mean?
cut.
Is that what you mean? According to the app, it's supposed to be Gaia 3?
no, not according to the app.
According to who
Look
then?
at the way the curve was.
Artificial
No,
intelligence.
Myself.
But I thought you
Let me
made
see
the
if
app.
It does not. No, look how the LEDs the takeoff is. Gaia comes with a pre-formed curve.
Do have
And
a,
I was worried I may not be able to make the turn, but looks like this is not doing anything.
yeah, so
Yeah, the-
we revert
Okay,
back to
let's see.
Gaia 3 according to the
Otherwise,
app.
I will change to Gaia now. Yeah.
Is there a factoid that can show the wire escalation up, please? In one of the multiple screens
Andrew,
we have.
can you put it on the side, the CTO wire
Yeah.
escalation?
Yeah, what's happening? Yes, I
the-
see. Yeah, I guess we are, but it's in a screen that I can barely see
you
from my
show
location.
only the
So
first
you
two
can look it
wires.
up. The
Don't have to
audience
show
can look
all
it
the
up
wires
there.
yet.
But the audience can look it up, but the panel and myself have hard time seeing what's projected.
Okay, now die.
That's great.
That's a good shot.
Okay. I have some.
We
So
have
get
a-
me the
So
Gaia then.
the tip end on that wire looks somewhat extreme to negotiate through that straight
So
LED
Miracle
segment.
is a very old generation wire, okay, compared to the current newer generation, Gaia Next. Gaia Next has a special core. They call it called as X-Trend. So 1-to-1 torque is a single core. 1-to-1 torque is excellent. Hydrophilic. Now the Miracle is a no hydrophilic coating. The current most wires are either polymer jacket along with hydrophilic coating. So they really help in antegrade. So now I'm changing it to Gaia 3 Next.
So
Gaia 3
So
next.
this is Gaia 3 Next.
Get a Confianza Pro 12. Don't open it though.
So it's something to say that, the wire bend in most cases
Or
really
next one.
is just a loop, and it doesn't really matter, but I still take a lot of time to make a good wire bend in your CTOs where you really try to get almost a double curve where the curve is really at the end of the wire so you can really move that tip around
Okay, it's going away, right?
as you're exploring to where the cap is.
I might add 2 points. One more
It's
generally
good.
about
Keep
the
going.
concept.
It goes somewhere.
The concept of anchoring, while it's very valuable, I think it has to be done with caution as you lose a lot of
I don't know
tactile
if
feedback.
we don't really know where the trajectory is. This seems
pretty
very
good.
good. The trajectory.
See, the wire tip is
Very
pretty
good.
Retrograde picture.
Very nicely done.
Let's do a...
Yeah, so do a
we are
retrograde
into the
injection, see where you are.
We are in the septal. Okay, ready?
Yeah, ready.
Might not have just gone that far, but
Yeah.
There you go.
I just have to get into the LED.
Seems like we're very good. We're in the septal. Let's see where we are though. Yeah, we have to be in the,
should go easy there.
to be in another branch to be sure, and we are sure now.
Okay, that's LED.
Beautiful, beautiful, beautiful. That was a great job. The Gaia 3-wire successful
Okay, take
wire.
another picture and document that we are in the digital vessel.
And
You never know.
yeah, I would say that this is,
Wow, where are we?
well,
not
well,
in
somewhere,
the-
but I don't know. Let's see,
I think
let's see,
maybe one of the branch.
let's see,
Wait.
let's see.
Oh,
Yeah, try to get in the main
table is
LED.
stuck. Yeah, we'll get into the main somewhere. I want to go to low Mac. Okay, some die there, or in the LED or somewhere outside.
No way. This is moving separately.
That's why the second view is always helpful.
Yes,
Okay, now,
yes, it is.
I don't know, it seems a little far off. I
it
think.
might have gone subintimal here itself,
Yeah.
yeah.
I may come all the way back to the proximal cap, because even re-entering there, you're going to lose, proximal branches.
How about a different view?
No, I think the curve, the little curve of this wire needs to point down as opposed to point up in a little bit further back. About, I think about a centimeter from the,
Yeah.
from the, right there, you're already going a little bit up. I think that might be the situation. You need to come back and go a little bit further
No
down.
die.
No.
Okay, right here, I need to enter into
A
the,
little bit further back, I'd say, a
Proximal
little bit
pressure,
further
yeah.
back.
this is why Gaia, as good as it is, the curve,
A little bit further back.
pre-made curve does not help most of the time.
A little bit further back. A little bit further
It
back.
does not matter, we need a little,
A little bit further back. How about trying an unmodified curve confianza? Just go straight, no curve.
I'm going to go to Confianza. Yeah, get me Confianza 9.
9.
Pro.
Pro 12.
Same thing, regular 9 or 12, what do you want?
Pro
Oh,
12.
he wants 12.
Pro 12,
Give him
Pro
12.
12. So we have a fast track
So Pro is
escalation.
same, Pro means there is a hydrophilic coating, then there is a regular non-Pro,
Yeah.
non-hydrophilic coating.
We're gonna need the
Okay.
coating a little bit.
Now die. That's subtle, I guess.
Is it worth taking an antegrade? Do you see any dye going?
No.
At exactly 10 millimeters or so after the tip of the fine cross, I see a slight deflection upward, which I think might be the exit. So somehow,
So,
Gotta
see, we
pull
took the
back.
fine cross, but the issue is the fine cross does not go any further. But let me get it at least into the proximal cap a little bit. Okay, get me the Confianza. So I'm going to take this out and go in with the Confianza Pro 12, as George mentioned. Wait, don't open, don't take it out. Do not remove the wire until you have your next wire ready. And I'm just going to make the curve myself.
I think if this doesn't look good, alternatively, we can downgrade pretty quickly to a jacketed wire.
John,
that
there
may
is a
knuckle and
microphone
tell you more
right here.
about where you are in the
oh yeah,
architecture.
go ahead.
I recommend that if I'm going to take a cranial LAO shot in the lateral view, that'll tell you how remedial or vital to the injury.
LAO cranial suggested
Yeah.
by Dr. LaSala.
I agree that another view, you'd like to see if and where you're leaving the vessel. I mean, in that one view, it looks like you're in a septal, but that can also be deceiving. And because I don't know that a Confianza Pro, penetration power is not necessarily your issue here. Right.
I would say just keep pushing.
No, John, I think I am subintimal. That's why we have to re-enter.
Too far.
But where are you? Where are you subintimal?
From the get-go.
Right here, proximal, right here. I am redirecting the wire.
Keep the redirected towards pointing down, that little curve point down.
Yeah. Retrograde die. Okay, right here, I think.
Yeah, why not different view?
No, it's going
Okay,
up.
what view? I don't think view is, they want eleocranial. I want to do anything. Good.
Different.
Now, if we have done, we have multiple channels. Somebody mentioned go back to polymer jacketed, downgrade, go to polymer jacketed wire. Not a bad idea either. But here, I don't think I've been in the lumen at all.
Well, I mean, that's why Dr. Huber and others suggested the retrograde, but, you know, sometimes you can get, be surprised. You just don't know. So antegrade always seems to be a trend these days. Even though if it's very difficult like this one, it's incredibly
I
difficult.
want to come back, antegrade.
Yeah, the
and then
ambiguity is really difficult here. So I think the resistance that we saw initially was promising, and it's just hard to tell where the guy is exiting. So sometimes just using that through that initial puncture and then maybe
Fielder
de-escalating.
ready.
Fielder again. I'm going to go back to fielder and see. I think definitely Gaia, if you see here, the way I think we made the entry, Gaia took us to the upper surface of the LED, right?
So I guess another wire can
And
take
we could
the-
never re-enter. That's why our confiance I was hoping will allow me to re-enter, but it did not.
Yeah.
Now they were saying go eleocranial. How?
You can, once you enter, we'll take one.
Okay.
Well, now we're away, so I would just stay here because this is the view that shows you the entry point, and once you make some advance, you can see something else. So the hope here is that this wire now will somehow take the entry of Gaia and then find a different way inside.
I mean, ideally you should re-enter the cap in a different location, but since...
Well, on the other hand, some wires tend to go high, parallel to the diagonal, for example, and I don't know, we dismiss that possibility, but sometimes the vessels make a loop, so it may go up and then go down towards the middle AD portion, not necessarily that is completely straight.
Gaia we make with the curve, right?
Yeah.
Get the Gaia 3 back again. I'm going to make the curve, extra curve on the Gaia, and see if that can...
So you're planning to
Want to take
re-enter
antegrade picture?
from scratch, right? I mean,
yeah,
that's probably
re-enter proximally from the scratch, yeah. Can you take
a good
antegrade
strategy.
picture, right?
And another strategy is parallel wire. I know we don't do that
Good.
much, but it's still an option if you get the wire in the
It's like there
wrong
is a
direction.
channel.
No, but that channel is not the best channel.
Along with re-entering, I think sometimes an angled catheter like a supercross will facilitate puncturing the cap. the
That is
proximal
another
cap
thing
in
we
a different spot.
should be. Now the question that, or do we even change to FCL guide before doing that? Do both. Okay, now.
Fielder. Fielder, fielder.
This could be the same, could be different, will die. Same.
So then maybe now do your other view.
No, we have re-entered into the same one, different. So what I want to do probably is, I think we will change to FCL guide, maybe the orientation could change, and then try the same wires again.